Hello everyone. So this is a right inguinal hernia repair done in a young male who's an athlete using the Da Vinci SI robotic system. We have used a fenestrated bipolar forceps, a curved monopolar scissor, and a large needle driver for the procedure. Before the start of the procedure, we have already put in our the mesh. So here we are developing the flap. We try and keep the flap very thin, it's just the peritoneum. That way we don't run into much bleeding. So the flap is taken from the ASIS towards the medial umbilical ligament. It's the ligament that marks the area of the bladder, and then we take the flap down slightly along the medial umbilical ligament. So here it is very important to recognize that most of the fat either needs to stay down with the flap or towards the vesicle area. So here you can see the pseudosac. We are gradually mobilizing the pseudosac. So this is a direct hernia. We stay very thin. All the fat is taken down off the Coopers. We gradually start visualizing the Coopers there. So we need to dissect about 2 centimeters inferiorly under the Coopers to make sure we've dissected all the hernia spaces, including the obturator space and the femoral space. So this is achieving the critical view of the myopectineal orifice, where you can clearly see the accessory obturator vein there. That's a marker that sits along the pubic tubercle. So having developed the medial space, we then develop the lateral space. This again is very thin. We try and keep all the fat away from the flap. That way we avoid exposing the nerves in the triangle of pain. All we can really do to prevent postoperative pain is try and keep the nerves undisturbed and keep them covered. After having developed the medial and lateral spaces, we come back down in the middle towards the triangle of doom and we dissect the cord structures. We try and keep all the fat out, take them away from the cord structures, bare the cord structures. And then we need to clearly visualize and make sure that there is no indirect hernia sac. The robotic system with the vision provides a lot of advantage here, because you can literally see the fibers. We can gradually dissect all the cremasteric fibers until we are happy that the cord structures are totally bare and we don't see any sac tenting. As we can see the vas turning medially there, and the sac is peeled back nicely and it's not tented to the vas or the cord structures. Once all that space is developed, a little bit more medial space, and then we are ready to put the mesh. So this is a large size textile anatomical mesh. We had already placed the mesh inside so that we could put it through the camera port. The camera port in the SI system is 12 millimeters, so the mesh goes in quite easily through that. So here we then don't need to undock, and there's hardly any movement if you've already put the mesh in at the start. So the mesh sits nicely in the pocket. We just need a little bit more space on the flap, and then the mesh was actually going to hardly move in the pocket. However, this is an athlete, so we prefer to fix the mesh, and we at least do a 3-point fixation of the mesh uh, in such patients. So either 1 or 2 sutures are placed to fix the mesh to the Coopers. This can be slightly tricky because you don't get very good vision through the 3D mesh because it tends to be a bit stiffer. We try to get some periosteum in our suture so that the mesh, and then we lift up and check that the mesh is anchored. Then we take another fixation suture medial to the epigastric. Once we clearly see where the inferior epigastric is, then we take a medial suture inferior to the epigastric. So this is a 3O suture. We've cut it to about 22 centimeter size length. So that's the medial fixation, and then we put one lateral fixation lateral to the inferior epigastric to remove any folding of the mesh and make sure that it sits nicely. The robotic system again gives us a lot of advantage here, makes it much easier to suture in narrow spaces in the pelvis. Even with a very small length of the suture, with the robotic system we are able to complete the suturing. We put one more suture to anchor the mesh to the Coopers there. And then we are ready to close the flap. So you can use a 2O or 3O, either a barbed or just a non-barbed suture for this. So this is a 3O PDS suture that we are using to close the flap. This is a barbed suture. Reverse suturing here helps us take nice bites of the flap, and then as we go medially, then even if the flap is very thin, we usually have some redundancy because it tends to be thicker medially and very fatty. So even if we have even if the flap is thin, it tends to become easier as we go medial. We can take 2 to 3 bites before we pull the suture. So here we are almost at the medial ligament, the medial fold, and once we have done that, then we take 2 to 3 bites back to just lock the suture. And that's our surgery almost completed. We remove the needle, we inspect the mesh placement, and we usually close our port sides. Thank you. The patient did very well at discharge next day.